oral lichen planus. Oral lichen planus is a chronic inflammatory disease that affects the mucous membrane of the oral cavity. It is a T cell mediated autoimmune disease in which the cytotoxic CD8 plus T cells trigger apoptosis of the basal cells of the oral epithelium. It's a body attacking the body. Several antigen-specific and non-specific inflammatory mechanisms have been put forward to explain the accumulation and homing of CD8 plus T cell subepithelially and the subsequent keratinocyte apoptosis. A wide spectrum of treatment modalities is available from topical corticosteroids to laser ablation of the lesion. I repeat again, lichen planus is a chronic inflammatory disease that affects the skin and mucous membrane. Oral lichen planus, the mucosal counterpart of cutaneous lichen planus, presents frequently in the fourth decade of life and affects women more than men in the ratio of 1.4:1. The disease affects 1 to 2% of the population, clinically seen as reticular, papular, plaque-like, erosive, atrophic or bullous types. Intraorally, the buccal mucosa, tongue and gingiva are commonly involved, although other sites may rarely be affected. Oral mucosal lesions present alone or with concomitant skin lesions. The skin lesions present as violaceous, flat-topped papules in ankles, wrist and genitalia, but characteristically, the facial skin is spared. That is reticular lichen planus, erosive lichen planus, plaque lichen planus. Oral lichen planus is a T cell mediated autoimmune disease in which the autocytotoxic CD8 plus T cells trigger apoptosis of the basal cells of the oral epithelium. An early event in the disease mechanism involves keratinocyte antigen expression or unmasking of an antigen that may be a self-peptide or a heat shock protein. Now following this, T cells, mostly CD8 plus and some CD4 plus cells, migrate into the epithelium either due to random encounter of antigen during routine surveillance or a chemokine mediated migration towards basal keratinocytes. These migrated CD8 plus cells are activated directly by antigen binding to major histocompatibility complex MHC-1 on keratinocyte or through activated CD4 plus lymphocytes. In addition, the Langerhans cells in oral lichen planus lesions are increased along with upregulation of MHC expression, subsequent antigen presentation to CD4 plus cells, and interleukin 12 activate CD4 plus T helper cells which activate CD8 plus T cells through receptor interaction, interferon delta and interleukin 2. Now the activated CD8 plus T cells in turn kill the basal keratinocytes through tumor necrosis factor alpha, FASL mediated or granzyme B activated apoptosis. The normal integrity of the basal membrane is maintained by living basal keratinocyte due to its secretion of collagen 4 and laminin 5 into the epithelial basement membrane zone. Repeat. The normal integrity of the basement membrane is maintained by living basal keratinocyte due to its secretion of collagen 4 and laminin 5 into the epithelial basement membrane zone. In turn, keratinocytes require a basement membrane derived cell survival signal to prevent the onset of its apoptosis. Apoptotic keratinocytes are no longer able to perform this function, and this results in disruption of the basement membrane. Again, a non-intact basement membrane cannot send a cell survival signal. Now this sets in a vicious cycle which relates to chronic nature of the disease. These are various lichen planus lesions. Hepatic virus infection and oral lichen planus. Epidemiological evidences from more than 90 controlled studies worldwide suggest that hepatitis C virus may be an etiologic factor in oral lichen planus. These probably suggest that hepatitis C virus specific T cell lymphocytes may play a role in the pathogenesis of oral lichen planus. The characteristic band-like lymphocyte infiltrate might thus be directed towards hepatitis C virus infected cells. Whether HCV infected patients have increased risk of developing oral lichen planus or patients with oral lichen planus have enhanced risk of developing an HCV infection is yet to be clarified. Differential diagnosis. The diagnosis of reticular lichen planus can often be made based on clinical findings alone. Interlacing white striae appear bilaterally on posterior buccal mucosa, and this is often pathognomonic. Difficulties arise when there is superimposed candidal infection. This masquerades the classical reticular pattern and in eliciting the erosive and erythematous forms of lichen planus. The differential diagnosis can include cheek chewing, frictional keratosis, lichenoid reactions, leukoplakia, lupus erythematosus, pemphigus, mucous membrane pemphigoid, erythematous candidiasis, and chronic ulcerative stomatitis. Lichenoid drug reactions are usually unilateral in distribution, accompanied by a history of a new drug intake. And the most reliable method to diagnose lichenoid drug reaction is to note if reaction resolves after the offending drug is withdrawn. Dental restorative material induced lichenoid reactions can be identified when lichen planus like lesions are confined to areas of the oral mucosa in close contact or proximity to restorative material, usually amalgam. And a positive patch test, a strong clinical correlation of proximity of a restorative and biopsy suggestive of diffuse lymphocytic infiltration rather than a subepithelial band, favor a diagnosis of oral lichenoid reactions. Clinically, lesions of lupus erythematosus most often resemble oral erosive lichen planus, but tend to be less symmetrically distributed. The keratotic striae of lupus erythematosus are much more delicate and subtle than the Wickham's striae and show a characteristic radiation from central focus. Biopsy of lupus erythematosus shows a characteristic perivascular infiltrate. Erosive or atrophic types that usually affect the gingiva should be differentiated from pemphigoid, as both may have desquamative clinical appearance. Both pemphigus and pemphigoid occur as solitary erythematous lesions and are not associated with any white striae. Now, this can aid in clinical differential diagnosis as erosive and atrophic forms of oral lichen planus usually show concomitant reticular forms. Peeling of epithelium from the epithelium connective tissue junction on slight lateral pressure in non-affected area, and that is called Nikolsky's sign, differentiates it from erosive and erythematous forms of lichen planus. Treatment: steroids. The most commonly used group of drugs for treatment of oral lichen planus are corticosteroids. The rationale behind their usage is their ability to modulate inflammation and immune response. Now, these act by reducing the lymphocytic exudate and stabilizing the lysosomal membrane. Topical mid-potency corticosteroids such as triamcinolone acetonide, high-potent fluorinated corticosteroids such as fluocinolone acetonide, disodium beta-methazone phosphate, and more recently the superpotent halogenated corticosteroids such as clobetasol are used based on the severity of the lesion. Superpotent halogenated corticosteroids such as clobetasol. The greatest disadvantage in using topical steroids is their lack of adherence to the mucus for a sufficient length of time. Now, although long-term use of topical steroids can lead to the development of secondary candidiasis, which necessitates antifungal therapy, the potential tachyphylaxis and adrenal insufficiency is high when using superpotent steroids like clobetasol, especially when used for a longer period of time. Systemic corticosteroids are reserved for recalcitrant erosive or erythematous lichen planus, where topical approaches have failed. Now, systemic prednisolone is the drug of choice but should be used at the lowest possible dose for the shortest duration, that is 40 to 80 milligrams for 5 to 7 days. Other immunosuppressants and immunomodulatory agents, calcineurin inhibitors. Calcineurin is a protein phosphatase which is involved in the activation of transcription of interleukin 2, which stimulates the growth and differentiation of T cell response. In immunosuppressive therapy, calcineurin is inhibited by cyclosporine, tacrolimus, and pimecrolimus. Now, these are called calcineurin inhibitors. Cyclosporine. Cyclosporine is a calcineurin inhibitor. It's an immunosuppressant used widely in post-allogenic organ transplant to reduce the activity of the patient's immune system. This selectively suppresses T cell activity and the main reason for transplant rejection and hence enhances the uptake of foreign organ. Cyclosporine binds to the cytosolic protein cyclophilin of immunocompetent lymphocytes, especially T lymphocytes. Now, this complex of cyclosporine and cyclophilin inhibits calcineurin, which under normal circumstances induce the transcription of interleukin 2. They also inhibit lymphokine production and interleukin release. Now, that leads to reduced function of effective T cells. Cyclosporine is used as a mouth rinse or topically with adhesive basis in oral lichen planus. However, the solution is prohibitively expensive and should be reserved for highly recalcitrant cases of oral lichen planus. Systemic absorption of cyclosporine oral rinse is very low and is, however, well known to cause dose-related gum hyperplasia, which reduces when the drug is withdrawn. Tacrolimus. Tacrolimus, also a calcineurin inhibitor, is a steroid-free topical immunosuppressant agent approved for the treatment of atopic dermatitis. It is nearly 100 times as potent as cyclosporine and has greater percutaneous absorption than cyclosporine. It has successfully been used in recalcitrant oral lichen planus cases. And this substance is produced by Streptomyces subcubicensis and belongs to the macrolide family. The immunosuppressive action of tacrolimus is similar to that of cyclosporine, although it has greater capacity to penetrate the mucosa. Tacrolimus inhibits the first phase of T cell activation, inhibiting the phosphatase activity of calcineurin. Burning sensation is the commonest side effect observed. Relapses of oral lichen planus after cessation have also been observed. The US Food and Drug Administration have recently issued a potential cancer risk from the prolonged use of tacrolimus and has recommended its use for short periods of time and not continuously. Retinoids. Topical retinoids such as tretinoin, isotretinoin, phenretinide with their immunomodulating properties have been reported to be effective. Reversal of white striae can be achieved with topical retinoids, although effects may only be temporary. Systemic retinoids have been used in cases of severe lichen planus with variable degrees of success, and the positive effects of retinoids should be weighed against their rather significant side effects like cheilitis, elevation of serum liver enzymes and triglyceride levels, and teratogenicity. It's a comprehensive review of oral lichen planus.